Very good afternoon to all. On behalf of Surgery Unit 4, I welcome one and all for the CCR. Sometimes life gives you marginal opportunities, and this case is about how we maximize the marginal opportunity that came to us. The case will be presented by a junior resident, Dr. Akshay. The review of literature will be done by Dr. Ramita, and the interoperative and the procedure will be dealt by Dr. Shushant and will be held by our colleagues from nuclear medicine. And now hand over the mic to Dr. Akshay.
Thank you, sir. Good afternoon, everyone. So today I'm going to present a story about this, two patients. One is donor and the other is recipient. So starting from the donor, our donor was a 76-year-old female hailing from Uttar Pradesh, presented to JP Narayan Apex Trauma Center with alleged history of fall from 5 to 6 flight of stairs. On arrival, her airway was compromised due to low consciousness and pooled secretions. Patient was intubated rapidly and cervical spine stabilization was done. And immediately she was put on mechanical ventilation. However, hemodynamically, she was stable, fast was negative. On arrival, her GCS was E1, V1, M4, and pupils were bilateral normal in size and reactive to light. On external injuries, patient had left ear bleed, suspicious of some middle cranial fossa fracture, and had one suture laceration over left parietal region. So to evaluate the patient, NCCT head was done, which showed fracture of left parietal and temporal bone, intraparenchymal hemorrhage of bilateral parieto-occipital as well as temporal region, midline shift to right, and intraventricular hemorrhage of lateral ventricle. So in view of this, patient was immediately taken to OT, and bilateral frontotemporal on-parietal decompressive craniotomy was done with surgical duroplasty. So unfortunately, on post-operative day 1, her GCS became E1, VT, and M1. Pupils became non-reactive to light, and cranial reflexes were absent. Patient required dual inotrope to maintain BP and urine output, or she was still on mechanical ventilation. So 2 apnea tests was done. Both came out to be positive. So patient was declared brain dead. And as happens with brain dead patients, patient's family was counseled for multi-organ donation, and gratefully we obtained the consent for multi-organ donation. So patient was planned for organ harvest. Investigations wise, her hemogram, kidney profile, and liver profile was within normal range, with creatinine being 0.7 milligram per deciliter and hemoglobin being 11 gram per deciliter. She was non-diabetic, viral markers were negative, blood group was O positive, and when we calculated the GFR, global GFR from CKD EPI equation, it came out to be 88 ml per minute per unit body surface area. Urinary protein was nil, cultures were sterile, and USG abdomen showed bilateral kidneys with normal size and maintained CMD with good flow. So patient was taken up for multi-organ harvest. Heart and bilateral lungs were declined in view of advanced stage, and liver functions were preserved. So liver was allotted to Army R&R hospital. Now comes the question of kidneys. So her global GFR was 88 ml per minute per unit body surface area. So now if we presume that each kidney contributes 50% to her global GFR, then single kidney GFR becomes 44%. So what happens usually in deceased donor transplant, that if a paired organ donation is happening, then each kidney gets a separate recipient. So that two recipients can be benefited by one donor. But now in this case, the single kidney GFR was 44%. That is low. Donor's age was 78 years. There is advanced age of donor and already deteriorating mass of nephrons with deceased donor transplant. So that might be the case that single kidney for recipient might be insufficient to take care of the metabolic needs of the recipient. So why can we not put both kidneys in a single recipient? So that comes with certain challenges. So first and foremost challenge was logistic challenges. This transplantation regulatory authority, the permission of transplanting both the kidneys into a single recipient, the permission had to be taken from Noto. So the permission was taken, recipient consent was obtained for putting both transplanted kidneys into a single recipient. However, retrieval of both the kidneys and also preservation was a logistic challenge. So after tackling all these challenges, patient was planned for multi-organ harvest, and pre-operatively she was optimized with adequate vascular volume with BP above 90 millimeter of mercury, mean arterial pressure above 60 millimeter of mercury, and the most important thing to maintain was urine output more than 50 ml per hour to ensure that the kidneys stay all right. So patient underwent multi-organ retrieval. As we had planned to take liver and kidneys from the donor, we put an abdominal cruciform incision starting from the Xiphis sternum to symphysis pubis, and the horizontal incision was put at the level of umbilicus. The liver was harvested by hepatobiliary team. Now comes the question of kidneys. So whenever you harvest the kidneys from deceased donor, what we did was we harvested the kidney en bloc. So en bloc means you harvest both the kidneys attached with a segment of IVC and aorta with renal vessels. So this figure A shows en bloc harvesting of kidneys, bilateral kidneys, and figure B shows posterior view of the harvested kidneys en bloc, and the aorta is being dissected. Now, after harvesting the kidneys, what we do on the bench is we perfuse them with a preservative solution. The preservative solution we normally use is a custodial that we usually use, that is a HTK solution. So now, after perfusion, we separate the kidneys. The en bloc specimen needs to be separated into two separate kidneys. So there are two things to be taken care of. One is renal artery division and one is renal vein division. So while dividing the renal arteries, what we do is we do not only divide renal arteries, but we also take some amount of aorta tissue wall, that is also known as Carrel's patch. What does it do is it makes the anastomosis in recipient a bit easier, and also it decreases the later vascular complication of anastomosis. The other thing that needs to be taken care of is renal vein division. So usual anatomy is right renal vein is shorter than left renal vein. So it might cause problem in anastomosis in the recipient. So what we do is, this is usual anatomy. How we tackle that problem is we divided the IVC just above the insertion of the right renal vein, and we sutured the upper end of the IVC, divided end of IVC with Prolene suture. And at lower part, we divided the IVC at around here. And while division of the renal vein, we also sutured that end with Prolene 6 suture. So ultimately, in effect, what we did is we used this segment of IVC as an extension of renal vein. So that takes care of the shorter length of the renal vein. So this was about donor. So till now, we have 2 kidneys with us that needs to be transplanted into a recipient. So now comes the other part of the story, that is the recipient. Our recipient was a 51-year-old female diagnosed as membranoproliferative glomerulonephritis 17 years ago with index creatinine of 2.6 milligram per deciliter. And she was on hemodialysis for last 4 years, regularly twice weekly, with left radiocapillary AV fistula as access, and her native urine output was 50 ml per day. When we matched our donor with the recipient, they were ABO compatible and CDC cross-match was negative. So now comes the time of surgery. 2 kidneys we have that needs to be transplanted into recipient. That also comes with some certain surgical challenges. So what are the challenges and how we tackle them? To discuss them, I would like to call Dr. Sushant, our assistant professor, to Dr. Sushant.
Thank you, Akshay, for this wonderful introduction. Now, certain cases come with certain challenges. In this case, we also had certain challenges. Now, what were those challenges? The challenge of space, whether the space is adequate for 2 kidneys, whether the length of the renal vessels is adequate or not, whether to go intraperitoneal or extraperitoneal, or whether to go utilizing both sides of the abdomen or single side. And also the number of anastomosis. We had to do 2 arterial anastomosis, 2 venous anastomosis, and 2 ureteric anastomosis. Now, after final assessment, we wheeled in the patient, laid the patient supine with arms extended, general anesthesia was given, and Foley's catheterization was done, and painting and draping was done. And the modified Gibson incision was placed. Modified Gibson incision was placed, and dissection was carried in layers. The external oblique aponeurosis was cut. The inferior epigastric vessels were ligated. Transversus abdominis muscle was cut, and space was created in the retroperitoneum. The aim was to expose lower end of IVC, the common iliac, and the external iliac vessels. And the whole of the retroperitoneum was exposed with the retraction of the peritoneum medially. Now it was time for anastomosing the kidneys. So the right kidney was placed and assessment was done. After assessment, and the right renal vein with a segment of IVC was anastomosed with the recipient IVC, and after that the right renal artery also was anastomosed with the recipient's right common iliac artery in the end-to-side fashion. And on declamping, though the kidney was pink and turgid, the urine output was minimal, and the clamp on-off time was 26 minutes. So you can see in the picture, this is the right donor kidney which is implanted with the segment of IVC as extension. Now the left kidney was placed below the previously transplanted kidney. The donor renal vein was anastomosed with the recipient's right external iliac vein in an end-to-side fashion using Prolene 6 sutures. The donor renal artery was also anastomosed with the recipient right external iliac artery in an end-to-side fashion. And on declamping, kidney was pink and turgid, but the urine output was minimal. As we can see, the previously placed kidney lies superior and posterior, and the later placed kidney lies inferior and anteromedially. And this is the ureter. Now, as we have anastomosed arterial, we have done arterial and venous anastomosis, it was time for us to anastomose the ureters with the bladder. So two separate anastomosis was done with the bladder using BJ stents, and the field was thoroughly examined for hemostasis, and two separate drains were placed, and the abdomen was closed in layers. Now, again, request Dr. Akshay to come and discuss the post-op course.
Thank you, sir. As important as surgery is post-operative course. So patient was managed post-operatively in a dedicated transplant ICU. Patient was put on immunosuppressant. Antithymocyte globulin was used as an induction agent. Thereafter, patient was maintained with usual triple immunosuppressant, that is tacrolimus, MMF, and Visolon. Patient was also put on higher antibiotics for the risk of infection, and hemodynamics were also managed properly. So this is the graph of how urine output increased. So after few initial days of low urine output that required 2 cycles of hemodialysis, patient started producing urine output at around post-operative 7 that peaked to 4 to 5 liter, and that stabilizes afterwards after post-operative 17 or 18 onwards. And so this is the trend of creatinine. Creatinine actually started falling from post-operative 10 onwards. And at the time of discharge, that is post-operative 9, patient's creatinine was 2.19. And patient's tacrolimus was maintained between 8 to 10 nanogram per ml. And we had also put 2 drains. So subcutaneous drain was removed on post-operative 4, and perigraft drain was removed on post-operative 5. Both showed minimal serosanguinous output, that is usual for initial few days. So after 5 days of transplant, we usually follow the transplanted kidney with graft kidney Doppler. So the transplanted graft kidney Doppler showed good flow at hilum as well as at origin with normal resistance index and resistance index within normal limits. We also do a renal dynamic scan for evaluation of the transplanted kidney. So I would like to call Dr. Anushna from Nuclear Medicine Department to discuss about the renal dynamics.
Good afternoon. This is the renal dynamic scan of this patient done on post-operative day 4. The upper panel shows the images during perfusion phase. This is the summed perfusion image. This is the time activity curve of left of right iliac artery and the transplanted kidneys during the perfusion phase. The lower panel images shows the images during the uptake and clearance interval. This is the summed uptake interval image. This graph is the renogram, which is the time activity curve, which is plotted with transplanted kidney count on the x-axis against the time. This is the prevoid image, which is taken immediately after the 17 minutes dynamic imaging. This is the 3-hour delayed static image. So in this scan, we can see the overall background activity is elevated, which correlates well with the creatinine levels during that time. The transplanted kidneys are visualized in the right iliac fossa. Here we can see there is a slight delay in perfusion of transplanted kidneys. Usually transplanted kidneys are visualized in a couple of seconds after the visualization of iliac arteries. There is impaired parenchymal tracer uptake with parenchymal retention of the radio tracer till delayed static images. So the overall scan findings suggest transplanted kidneys in the right iliac fossa, which shows impaired function and persistent nephrogram. The differentials for persistent nephrogram are acute tubular necrosis and drug toxicity. These are the zoomed in images which I have shown previously for the better understanding. These are the prevoid image and the delayed 3-hour delayed static image. Here we can see the transplanted kidneys. This is the second renal dynamic scan of this patient done on postoperative day 22nd. Here we can see the background activity has significantly reduced. It is only mildly elevated. The transplanted kidneys visualized in the right iliac fossa with preserved perfusion, and there is prolonged parenchymal transit, which is shown in the time activity curve. And another important finding, in the previous renal dynamic scan, the bladder was not visualized. Here bladder is visualized. So the scan findings are transplanted kidneys in the right iliac fossa showing preserved function, prolonged parenchymal transit, and delayed clearance. As compared to the previous scan, there is significant reduction in the background activity with improvement in the function of transplanted kidneys. These are the zoomed in images. This is the prevoid image, which is taken immediately after the dynamic study, and this is the 3-hour delayed static image. Here we can see the 2 transplanted kidneys in the right iliac. Yes. This is on postoperative day 4. This is on postoperative day 22nd. Thank you.
Thank you, Dr. Ramkrishna. So on follow-up, we are following the patient up after 9 months of transplant. Now current creatinine is 1.2 milligram per deciliter. That value is of 7th of November. Now for the review of literature, I would like to call Dr. Bhamika.
Thank you, Dr. Akshay. So coming to the review of literature, what we can see is that the treatment of choice for chronic kidney disease is renal transplant. But the demand for organs and the number of donors available, there is a huge gap. Coming to the Indian scenario, there is a high demand. The organ donation rate is less than 1 per million, while the number of organs needed is 65 organs per million. There are cases of 1.8 lakh renal failure cases in India, and the number of transplants that we have is only 6,000. Also, there are challenges related to accessibility, availability, and affordability. We also lack appropriate cadaver transplant programs in India. Above all, the living donors are more in number than the deceased donors, in contrast to Western literature. We have achieved milestones, as we can see that there is an increase in the slope from 2012 to 2015 in the number of deceased organ donors. The milestones that we have received are more than 1,000 deceased organ donors in a single year for the first time in 2023, and the deceased donor transplants have increased from 837 in 2013 to 2,935 in 2023. So, deceased donors, there is standard donor criteria like normal renal function test, no hypertension requiring treatment, no diabetes mellitus, no malignancy, no generalized viral or bacterial infection, accepted urine analysis, negative assays for syphilis, hepatitis, HIV, human T lymphoproliferative virus. But what about those donors who are age-old or those who do not have proper kidney function? Do we discard them? No. We have expanded donor criteria for them. So there is expanded donor criteria for motor and also United Network for organ sharing. As we can see that the donor age can be more than 60 years provided the other parameters are normal. And for those who are 51 to 59 years, we also accept those who have two of the following like high blood pressure, increased creatinine levels, or death from stroke. UNOS, United Network of Organ Sharing, have their guidelines for expanded criteria donors, also known as the marginal donors. But what are the contraindications to this? Those who have chronic renal disease, current intravenous abuse, untreated sepsis, severe hypertension, oliguric, acute renal failure, HIV positive, juvenile onset diabetes, and potential metastasizing malignancy. Age more than 75 is also a contraindication, but those who have provided that the other parameters are normal, we can accept these patients as marginal kidney donors. And this was our case where the donor was more than 70 years, she was 78 years old. So going back to history, the first reported dual kidney transplant was done in the University of Maryland in Stanford. But Lloyd Wagner, it is documented that he performed the first dual kidney transplant in 1993. The unilateral placement of two grafts extraperitoneally through a single incision was done in 1998. So what is the prerequisite? We need adequate nephron mass pre-transplant, which has been seen in animal models. So nephron mass is a determinant of allograft, chronic allograft failure. What is the physiology? Suppose the kidney has adequate GFR, then in spite of the administration of immunosuppressive agents to the recipient because of the nephrotoxic effect of the drug, there will still be a gradual deterioration of the function causing chronic graft dysfunction later. But what if the kidneys are having those of marginal donors which have inadequate nephron function when singly transplanted? This will lead to more chances of early graft dysfunction. Here comes the usage of dual kidneys, two kidneys in a single recipient. The cumulative function of the nephron mass will be adequate. So if the nephron mass is adequate, here comes the function of marginal donors, where we transplant two kidneys in the same recipient. So what are the types of dual kidney transplant? It can be bilateral placement, it can be unilateral placement with patch anastomosis, or it can be unilateral placement with separate anastomosis, which was done in our case. What are the advantages of this? First of all, the incision, we make only one incision. Second, the ischemia time is reduced. Third, the benching time is also reduced. The drawback of unilateral placement with patch anastomosis, the benching time is more. And for bilateral placement, again, the number of incisions, that is two incisions, one on either side. But when the outcomes of these were studied in a recent study where they compared the dual kidney transplant techniques, it was found that the outcomes were almost the same. The graft survival is more than 90% in bilateral placement, unilateral with patch, and also unilateral separate. And the delayed graft function was also between 20 and 30% for all the techniques. For the other literature, what we found was that the creatinine levels when comparing single kidney transplant and dual kidney transplant, the 18-month follow-up creatinine was lesser in the dual kidney transplant than in the single kidney transplant. When we check the outcomes of dual kidney transplantation, the graft survival at 8 years was more for the dual kidney transplant than the single kidney transplant. But everything comes with advantages and disadvantages. What are the disadvantages of single kidney transplant? As mentioned, inadequate nephron mass causing early dysfunction or maybe primary non-functioning. What are the advantages of dual kidney transplantation? We can use those marginal donor kidneys. So we do not discard those kidneys. And the survival rate with expanded criteria donors was more than those who were maintained in the waiting list, those who were more than 60 years old, according to European literature. Also, there was 30% improved filtration from single kidney transplant recipients when compared. A recent study was done in the UK where they compiled data from 2005 to 2015 and they compared the single kidney transplant and dual kidney transplant from deceased donors. As we can see, kidney 5-year graft survival or the median EGFR was more in case of dual kidney transplant than single kidney transplant. Thus, marginal donors, when 2 kidneys were given to one recipient, was more useful. But again, dual kidney transplantation also has its complications. The delayed graft function rate, be it any technique used, range between 20 to 30%. The graft thrombosis rate, be it any technique that was used, range from 2 to 5%. And the most common complications were the same as that of single kidney transplant, like wound hastens, hematoma, urinary fistula, and lymphocyte. Thus, this was the first adult dual kidney renal transplant in AIIMS, New Delhi from marginal donors. To conclude, dual kidney transplant from elderly, that is marginal donors, is a viable solution, addressing the demand for organs and also maximizing the resource utilization. I would now like to invite Dr. Krishna for the conclusion and acknowledgements.
Thank you very much. As we say that it's always a team effort, and we like to acknowledge the help provided by the Department of Nephrology, Radiology, Anesthesiology, Nuclear Medicine, Transplant Immunology, and all more. And a special thank to Professor V. Shinu and Dr. Bansal, who has trained us all, and it is because of them that we are here today. I'd like to now open the house for any questions and discussions, please. Yeah. Yeah, it has been actually, I think Arun will agree, Arun is here from nephrology, that the more elderly the patients are, the graft outcomes are actually worse. Because obviously, as with age, the nephron mass slowly deteriorates. So obviously, and that is the reason we took both the kidney. If you would have taken a single kidney, then the nephron mass might not have been adequate for a recipient of 40 to 50 years of age. Putting both the kidneys gave the patient a better chance of having a kidney functioning for a longer period of time compared to that of single. Obviously, we deprived another recipient from getting a kidney because we utilized both the kidneys in a single recipient. But yes, that worked. That helped the recipient in which we transferred both the kidneys. It's a little technically challenging. You see that we are actually placing both the kidneys. So the overall, the warm ischemia time, that is the clamp time, actually increases. So that's why we first place the upper kidney first, so that we can perfuse it. We declamped it, and then we clamped it below, so that the upper kidney continues to be perfused while we are placing the second kidney. So this decreases the overall warm ischemia time of both the kidneys. Yeah, separately, always separately, because you don't know the vascularity of the cadaver transplant is different from liver kidney transplant because the vascularity, everything is all questionable. You don't know how the kidney has been taken out, how it has been provided. So in AIIMS, we have the luxury of being the retrievers as well as the implanters. So we know what is the quality. So, but usually it is recommended that you place the ureters separately rather than making a pajama and putting them, because the vascularity is questionable in cadaveric transplant. So it is better to place them separately. Sir, actually, Yeah, yes, sir. You are absolutely right. That's a good question, sir. Actually, sir, it's very difficult for two teams to work together while doing a transplant. It's not like two breasts separately, but in transplant, because you have to put the retractors, there has to be retraction, and it's very difficult for two teams. You can make the bed on the opposite side, but putting a kidney and doing the anastomosis is actually challenging for two teams to work simultaneously. Obviously, the overall wound morbidity actually increases. You are going to put two big incisions. They are immunosuppressed patients. The wound infection rates are quite okay in the Indian level. We tend to have some wound infection. Single side, yes, it is technically a little more challenging, but the overall morbidity is quite low compared to bilateral placement. Actually, बहुत challenge होता है सर दो side two teams working with. Yes, sir. Sir, usually if the thrombosis has to occur, it occurs in the transplanted vessels rather than in the native vessels. So if the native vessel definitely, if patient is a prothrombotic state and the native vessel goes, then invariably both the kidneys go. But this can happen even if you place the bilateral. You can have a native vessel thrombosis on both sides. Yes, it is. There are certain diseases like IgA nephropathy and all, which can occur in the graft, and usually patients are counseled and told about that before we transplant the kidneys. Yes. Sure. Thank you. Thank you. The dual kidney has not been attempted. We have done en bloc kidneys in pediatric. That's small kidneys when we have pediatric 2 years donors, 3 years donors. Actually, we were the first to do the en bloc pediatric also. That we have done. That has been, I think, so it has been more than 4 or 5 years that we have been doing it. But adult dual kidney, actually, Arun also, this is the first time they've done. We have done a transplant from a 75-year-old, but we took a single kidney. But this is the first time we took a dual kidney. Yeah. Now we have a lot of transplant surgeons now. Availability has increased. Both the kidneys. Actually, we have to work the whole night. We have to work the. So that's your after. But actually, for this case, I had to at least make 20 calls to ensure that we get both the kidneys, because Noto usually has a policy pair kidney, two other centers. But here I had to talk at every level to get both the kidneys. Yes, we can understand this. If you can get absolutely why not get it to 2 people? But at the same time, if the outcome of the survival is not one patient. Yeah. Yeah, at least we are making one patient's life much better than compromising the life of two recipients. Yeah. Everything. Thank you very much. Thank you very much.